Okay, so looks like Dr. Kumar is ready. And let's go to the live case. Dr.
Yeah.
Kumar, you are.
We'll introduce the team here. To my right is Dr. Vivek.
Hello.
And he'll be assisting me in the case. Vikram, he is our technical expert. Dr. Kavita, who is with me, and my OCT team is there. So we have a case who is. Vivek, can you just show the slides for the case study?
The history, please. So,
just show me the
history.
Yeah. So this is a 60-year-old gentleman. He is a diabetic, hypertensive smoker, presented with recent onset of angina, dyspnea class 2 for 6 months. So he was screened with a treadmill test, and that was positive, moderately positive. Echocardiography was normal, so no RWMA, and the ejection fraction was 55%. So he had a coronary angiogram done, and that was, I will show you the coronary angiogram, which showed, all three arteries has some lesions. So you could see that the very short left main on the screen. Can you see the angiograms?
Yes, we do see them.
So you could see that the circumflex system is small. The ramus intermedius has moderate to severe stenosis in the proximal segment. Can we see the cranial view on the LAD? You can see that there is a moderate stenosis in the left anterior descending artery. Just after the second septal, there is a significant borderline looking lesion. And then can we see the aleocranial view?
Just we have this.
Can we show the right artery? Right, yeah.
Right, yeah, we have a right.
And this is the right coronary angiogram. You could see that again there is a moderate stenosis in the mid segment of right coronary artery. Can we have the other view also? Yes, so this is in right RAO view. The right coronary artery looks little more stenosed than what it looked in the LAO view. So this is the case for you today, and we thought that we should do a functional assessment of the arteries, because the borderline lesion in LAD and the right coronary artery, and then there is a moderate stenosis in ramus. And since he had symptoms and stress test was positive, so what does the panel feel that how should we proceed in this kind of case?
Okay, Dr. Kumar, thank you for setting it up. We'll go to our panel. We have an expert panel here. We've got Dr. Mappin from the Netherlands, Dr. Kofal from the Czech Republic, Dr. Iqbal from India, and Dr. Cho from Korea. Dr. Cho, how do you take on this case back home?
I think that the mid portion of RCA should be treated because it is significant as it is. So and the mid LAD, maybe you can do FFR to check, but I don't think we need to treat the mid portion of LAD. So it's my opinion.
Anybody else on the panel have any?
I completely agree. LAD is maybe significant. It could be done by FFR, and right coronary artery is significant, sure.
So we're doing a study right now that I'm the PI on proximate intermediate stenoses and using physiology. And you'll be amazed how any lesions between 30 and 60% in the LAD proximate, how many of those actually are physiologically significant when you actually test them with FFR. So I'm curious as to what the LAD would be like. I would like to FFR both, but that would be my own preference, just so that I know what I'm treating. Dr. Vivek?
Yeah, so I think as the panel agrees,
I agree too.
the functional assessment is essential, isn't it?
Stenosis like that in the LAD will very often be positive on FFR. Stenosis like that on the CX,
so I think we had both the views.
So go ahead and proceed. And
so we did FFR to the right coronary artery. So can we show the results of FFR on the right artery? Can you show this screen? This screen. So as you could see, we thought that probably the right coronary artery will show. So we always use the infusion of adenosine, and then so you could see that the FFR of right coronary artery was 0.85, and though it looked more significant angiographically, but it did not show any significant on FFR. So functional assessment is important. So as you could, can you see on the screen the FFR of the right coronary artery?
Yes, we see it very well, yes, 0.85.
Yeah, so then again we did the FFR for LAD, and so to our surprise the LAD was quite significant. The FFR in LAD was 0.77.
This is exactly what we've been seeing
We
on
did
a
a pull
routine
back also.
basis, looking at
Yeah.
what we call intermediate disease in the proximate LAD because of the amount of myocardium that it subtends.
So we thought that we will treat this lesion with absorbable technology, Meril 100. So we will have to use the imaging also. So we would first do an OCT, and then we'll size it and put a absorbable scaffold that is Meril 100.
I think it's a very nice.
So we have
case.
taken out the, because for the
I just
The-
like to
the
add a comment. If I
FFR
can.
wire we have taken out because, yes please.
Go ahead, Paul.
So if I mean, we know from the early days when FFR was introduced by Nico Pijls and the likes of Bernard Bruyne, that you should ideally, when you have, especially in what appears to be a somewhat borderline fractional flow reserve, do an FFR pullback to see what the jump is.
Yeah.
If it's not a gradual decline, but actually you have a significant jump over a short segment, and looking at the lesion, that's probably
We did
true.
a pullback.
But
Yes.
as long as you have the IV adenosine
Yes.
running, it's low-hanging fruit just to do a pullback and to see where you need to
Yeah.
start stenting and where to
Yeah.
stop stenting.
So that's what we did. So we do it quite regularly, and here we found that across the lesion there was significant jump. So that made our decision, and then so we thought that it's quite significant. So you are very right that pullback in infusion is much better.
Yeah, where is it?
So what FFR
We are ready.
technology are you
It was
using,
okay.
Dr. Kumar? This is the St. Jude, the Abbott system.
Yeah, so we are using the now Abbott
Yeah.
to St. Jude technology. So we would do an OCT of this lesion and then size it, and accordingly then we'll prep the bed as any absorbable technology is, and then we would do an optimization again with the OCT technology.
So you're using imaging sort of to not only size, but look at the properties of the
Yes,
of the plaque in order to do the appropriate PS.
yes, that's right. Absolutely. So can you flush it? Can you make it here? Yeah.
Right. probably.
How many people in the audience have OCT in their labs? Please raise your hands.
Ready? Ready, sir. So we'll do an hand injection and see.
It's quite tight.
So can you show the images on the main screen? Can you read the OCT? Yeah. So on the main screen now you can see the OCT images.
Yes, you see that.
So distally you could see that it's okay, there is no lesion. So can you come to the lesion segment?
There's some plaque there.
Yeah, plaque there, and there is some calcification in the.
See some calcification.
Can you just yeah? So yeah, and some fibrotic character also, and then there is a branch there. So I think the size is almost 2.75 to 3 millimeter.
So that's your proximal left landing zone.
It's almost, yeah, yeah. So proximal landing zone is
2.2.
yeah.
Quite a long
2.6.
segment as well.
Yeah. So I think we would cover the whole segment with the. So first we will do a good pre-dilatation and prepare the bed. So can we have a 2.75 into 12?
Length? हाँ 10.
That's the problem with stenting OCT guided. You should go from the healthy bit to the healthy bit. But after when you do OCT, there is
Yeah,
no healthy
yeah.
bit.
No healthy bit,
You know,
just a
it's diffusely
Yeah.
diseased. So that's one of
So
the problems. By
end
the
up
way,
end
I
up
have
using
to
a long.
I have to compliment on the image quality by just a manual injection.
Yes.
This is truly amazing that
yes.
you don't need a power injector in all cases. You can get these wonderful, entirely blood-free images
Yes.
just by manual injection.
Absolutely, yeah.
Yeah, so I think the guide is very coaxial, so that helped us in getting the good view.
How much?
Be careful calculations to, number one, size appropriately, number one, two, to land in proper, healthy distal bed. And you'll see in the next lecture, if you do this correctly, you really can accurately place any stent
Connect.
with really very good durable long-term results, I think. And this is what aluminum
Yeah,
4
that's true.
is going to show, which is a
So
study
we have
about to start.
so doing a pre-dilatation with 2.75 into 13 millimeter balloon. 12, 14, 16, 18, 20. Negative. 14, 16, 18. Yeah. Negative.
Short.
So can we get a 3 into, which is the longest scaffold? 14, 16, 18. Go up, please. So we would be
14,
using a long
What
stem
time we
to
need a
cover the
dilatation
whole
here?
plaque.
Yeah, you need at least 30 millimeters.
So longest 3 also will be using, yeah. So we'll use 3 into 33.
Yeah, that should be perfect.
Yeah. So 3 into 33 Meril 100 absorbable scaffold. So we will follow the same principle. We'll go slowly on the dilatation, give time for the scaffold to expand slowly, and then we'll do aggressive post dilatation with 3O balloon within the lumen, and then again we will do post dilatation. So this is, if you can see, the Meril 100 scaffold. So it comes with a cover. So we need to just pull it off the sleeve. So this is how it. So those who have used the absorbable scaffold will be aware that we need to be careful with this, and we should slowly inflate this device.
What has been your experience with deliverability?
So this is 330.
Kumar?
332.
Pardon, sir?
What has been your experience with the
Our-
deliverability?
So this is much more deliverable. So I would say that's better than the Abbott scaffold absorb. So this is quite easily it goes. So I have used it in tortuous segments also. And deliverability is much better.
Ready for
Can
the
you
shot?
connect?
Yeah.
Are you- So we'll take a check shot, and that we'll try to be so called within the healthy segment, because there is, if we try to cover whole plaque segment, then it will be very long. So we'll come a little bit down. Yeah.
That's very good.
Maybe that septal.
So I think we'll deploy it here
Yeah.
slowly over 2, 4, 6.
This
So
is
the
not
nominal is 9 atmosphere
9
for this.
atmospheres, okay.
Yes. So we would go at nominal, wait for 30 seconds, and then we'll take for post dilatation another balloon NC. So it seems that it's fully expanded. As you could see that if you can zoom on the distal end and the proximal end, there is 3 markers. You could see they are lead 2 on the one side and other 1 on the
seconds.
middle side. 30 seconds up. Negative, please. Can we show it on the stent boost?
Stain boost. Stain boost. Have a
Stent
stain boost, please.
And collimate it. Can you show the stent boost?
Fluoro, please. Sir, fluoro.
It helps in finding the markers on the stent boost quite easily. Ready? So can you show the stent boost on the screen? So you can see there are 3 markers, which is like making a triangle kind of thing on both distal and proximal end.
Yeah,
Can
we
you
see that.
appreciate it
Yes,
there?
we see that very well, huh?
Yeah. So that is on this screen. Yeah. So we'll take a check shot and then do a post dilatation just to make sure that there is no edge dissection or anything like that.
Three balloon should be ready.
3 balloon, 3.
Yeah. Beautiful.
So this look okay. The distal end is slightly oversized. So proximally we have to do more optimization. So can we have a 3 into 13?
Yeah, we have a
So we have mosaic balloon
313,
NC
please.
313. So as you know, we can go up to 0.5 millimeter quite easily for post dilatation. But in this case, the sizing looks good, and we have the imaging technology also. So we'll reconfirm it before going more than 0.25 size in this case. Can we have the?
Yeah, sir, we are just in a minute. Thank you.
So you clearly
This
see
some
that the
NTG.
stented segment needs to be post-dilated.
Yes.
Are you going to take a slightly...
So we have taken the post dilatation balloon.
Which size are you picking?
So we are taking 3O balloon for the distal, and we'll take 3.5 for the proximal end. With proximally it's bigger. Just get a 3.5 balloon as
Yeah,
well.
3.5 also very.
So we will take the help of these good markers. Boost please. 12, 14. So you can see on the stent boost, you can clearly see the distal edge. So the risk of going beyond the stent edge is very, very unlikely with this.
14.
14, 16, 18. Negative. 18, 20. Negative. So we are doing it very high pressure dilatation, and then proximal end we will again touch up with the bigger balloon. Boost please. This out.
Yeah, it's out.
Boost again.
It looks okay.
14, 18.
18.
20. Good. Down, please.
We'll do an OCT and check.
So we'll do an OCT imaging and then see whether we need to go up. How many of you feel that we should do 3.5 millimeter dilatation beforehand?
We'd like to do a 3.5 dilatation in the proximal part of the stent. Raise your hands.
Yeah, so
Very, very few people. But I think
very
that-
few. So let's do an imaging and then see if this is required. We'll do.
3.5 is probably
Yeah.
reasonable, 3.25 at least. The OCT will tell us.
Anurag, we are ready with this.
Can you hold the paper?
Yes, sir, please.
Walk with me.
Yes, sir, sure.
So you've taken the OCT catheter now, and we'll again see whether it is well apposed or needs to do anything further. It's very important that we should look at the distal edge of this stent in the scaffold things very carefully, because sometimes after post dilatation, if we are out, then the chances of edge dissection is very high. So we'll take a shoot. Can you just flush it?
Yeah.
I'm ready whenever you say. Yeah. Yeah. Opacification is okay?
Yes.
Yeah, so we find that there is a good opacification. So here you can see on the main screen, can you make it bigger? That, can you just scroll through the stented segment so that we see the apposition is good?
So that's the distal segment.
So this is the distal segment. You can see very well embedded. The small squares of the scaffold is there. And all the way we are coming to the proximal segment. So you could see that there is one small area where the apposition was not good. Here again,
Branch.
so it's not much significant, but this is where the scaffold ends. So I think it's very well apposed. And do you have the 3D reconstruction?
Yeah, there's no edge dissection distally or proximally.
Okay. Yeah.
Very good landing
So there is no
zones.
edge dissection. Yeah. It looks good on that. Anybody who wants it to be dilated with 3.5 in proximal segment?
The MLA at the lesion site.
I would do the measurements.
Can you do the measurements, MLA?
Measurements, MLA.
12.92 centimeters per standpoint.
Okay.
Provide us a post-standard FFR because I'm curious how much increase there
Yeah.
is pressure.
Yeah, so I think that's very good point. We should do a post stenting FFR and see how it goes. Can we
Adenosine.
get the FFR wire and adenosine
Yeah, I
going
think that's
on,
a
please?
great idea. It's a great idea. How to do that.
What we see,
Yes.
Paul already elaborated on that in seemingly
Yeah.
non-heavily diseased LADs, you see a lot of reasonably low FFRs. So there's a gradual decrease, and at the end of the LAD, which this one is huge,
Yeah, it wraps around the idea.
it will be 0.82 in a healthy LAD. I think there's always some
Yeah.
pressure loss in the LAD lesion.
Can we have the wire?
Yes, sir. We'll have to
So we are
recalibrate it.
planning to do an FFR post procedure because the OCT looks quite satisfactory. Can we equalize that with the FFR wire?
That's very interesting because
So it will
according
take 2
to
minutes.
Professor Nico Pijls, we should aim for a fraction of flow reserve at 1.9 post-procedure.
Yes.
So good luck
Yeah.
with that.
5 ml and drop here.
Yes, let's try.
Just add one.
While we are getting it in, how many of you end up all the interventions with FFR?
We don't routinely do it because the results are so dissatisfying. We'd rather not know.
Yes. Yes. Yeah, so
so
I
we're
think
we're starting to look at
that's
that
the
a little
same
bit more
story.
in certain cases, especially when we're surprised about physiologic lesions, especially intermediate disease.
And could you make sure that you that you position the pressure wire at the same location where you had obtained that FFR of 0.77?
Yeah, that's correct. You don't want to be any further down.
So we can have that reference image then.
Just go to
Yeah. We will.
Yeah.
Just outside the right. Proximal opaque matter should be outside the right. Yeah.
You can even zero it in the circumflex, it's okay.
Check करो.
Yeah, you and the yeah. We have to equalize.
Yeah. Just a minute. So we are equalizing now.
At the left main, sir.
Bring it back.
Left main. Yeah.
Okay, sir. Okay.
Flush the guy.
Okay.
Sir,
Equalize. कर दिए? Okay.
Okay, sir, cross.
Good.
Cranial, please.
balloon ले लें.
ठीक है, you will test it.
नहीं, wire खराब हो रहा है. हाँ? Wire has got little. हाँ? नहीं, इसमें वो ले लेंगे. Balloon leg. I think you have another wire.
We'll need
सीधा
another.
करो. इसको इधर करो.
Yeah.
So I think we have slightly traumatized this wire. We'll use the other one.
Yeah, these wires are very difficult once they're bent.
I think I would stop here, Manish. I don't. Once you get an OCT and we don't know what we're going to do with the value, and as we mentioned, what is the rightful post PCI FFR value? Are we trying to get 0.94 or 0.99? Or
No.
It's more to display the fact that it's probably 0.82.
Right.
And
Can we have the
but
other
just
wire?
for the educational purpose for a life case course, because it has no clinical relevance.
Exactly.
Yeah.
And actually take into consideration in a live case when the wire
Flush
is
it.
getting damaged in a recently placed scaffold, there's more trauma that probably will happen to the vessel trying to repeatedly attempt.
Yeah, no, I think it's a very reasonable point. I think his concept of doing it, and by the way, there is going to be a randomized trial.
You'll have to take it out.
Post
You'll
PCI
have to take it
FFR
out.
that's going to be done to look at just the relevance of this and what it means long term, because we don't have a lot of answers on post PCI, both FFR and IFR, for that matter. You know, from my perspective, I might use a 3-5 balloon in the proximal stent and call it a day. If you can get the FFR wire down safely, will be interesting. That's about it.
Yeah, so that's what we're trying to do. Just show me.
On.
Give me.
Okay.
So we're using the another FFR wire because that tip was slightly broken.
I've started to use more of the fiber optic technologies because of its durability and its steerability. Although you cannot take away that
that's true.
the data that we have is from the St. Jude FFR product.
Hello, Chitu. Let's check, please.
We have also encountered some issues with drift. So I think a fresh wire here is
Equalize.
Ah.
Yeah, we have to equalize, sir. Yeah,
Ah,
that's it.
equalize? No, no, just
Just
Abhi
wait.
nahi. Equalize. ठीक. Equalized? Okay. So we have equalized the pressure wire. Now we are crossing the lesion. इसको इधर थोड़ा टर्न नहीं कर रहा ना. Start करो.
The bend is no out.
Neither just on outside.
Yeah.
yeah, these are very
Nikal.
poorly steering wires.
Yeah, so that is.
Yeah. Sir.
I often steer from the back torquer.
Yeah, so that's what we're trying to do now.
Also maybe an argument for post-dilating that
Yeah.
proximal stent bigger. That's,
So we'll do the post dilatation after the FFR.
Sure.
See. Can we have the flow, on flow, adenosine?
Are you ready for the infusion?
So your resting is 0.97.
0.97, 0.98, yeah. Can we get the adenosine?
Earlier it was 0.93. Infusion.
On? Yeah, started? Good. So you started the infusion. The earlier value was 0.93, the resting one. Now it's 0.98. In the meantime, can you get the 3.5
3.5
balloon?
balloon, please.
Timer on? There's some issue with that infusion.
Now you're starting to see a little adenosine effect.
NTG? ACT कितना है?
ACT was 260, we gave 3001.
Saline थोड़ा चला दो.
So we have right now. It's
So it's coming 0.94.
Very good. Very nice.
But nonetheless, we will again post dilate the proximal end with 3.5 into 13. you will go on the FFR wire itself.
I think that's totally reasonable, and then you're finished.
Can you just...
This is what our hypothesis is going to be, is to have it greater than 0.9 and see what that means with patients less than 0.9.
So the proximal end will dilate with 3.5 and then take a final shot. Can you connect it?
Yes, sir.
Post-dilatation, there's still some workmanship in the business. You can see you were not happy with the feeling with the wire on the proximal end of the stent.
Yeah, so I think once we had difficulty in proximal end, it's better that we end up with a post-dilatation. Can you get the boost? Stent boost, please. 12. 12, 14. 14. So this is 3.5 into 13, so we have gone up to 14 atmosphere. Negative. Mid 9, 10. 12. Negative. Negative. A shot. We'll take a shot with wire and then final shot. Okay, so I think this is looking good.
So we're looking at the OCT right now.
We have
We're not
confirmed
looking
with
at
the
angiogram.
yeah. Can you show the angiogram on the screen?
There you go.
Do you
Sure.
want another one? Yeah. Yeah.
So this is the final pictures.
Very nice.
So I think we thank all my colleagues here for helping me in this case, and Meril Life Sciences for giving this opportunity. Thank you, Manish, and all the team, the panelists, everyone for contributing in this case. And over to you, Manish, and the Meril coordinator there.
Thank you
very
so
much
much,
for
Dr.
your
Kumar.
kind attention.
Thank you. Great demonstration.